Brilliant, thank you very much for coming. So I'm Craig, I am 1/3 of the urology team. We've got Maggie here, who's a member of our team, and then we've got Bev Wilkinson, who's one of the consultants at the Hallamshire, who's here for moral support. Thank you very much for coming. So today I'm going to cover, we're going to split the urology section into two parts. So I'm going to go first for about 20 minutes, then Maggie's going to cover some other topics. Now I've really aimed this at covering quite a few topics that I want to give you some nuggets of information and some stuff that I think would be really useful for you to know about. So I'm going to cover, so yeah, recurrent UTI in women under 60 years old, some imaging queries, assessment of male lower urinary tract symptoms, and PSA and prostate cancer screening. So I'm not going to mess around, we've got 20 minutes, so start with a scenario for you. So you've got a 38-year-old lady who presents with dysuria and frequency. She's treated with 3 days of nitrofuran tone by the pharmacy. She represents 4 weeks later with UTI symptoms again. You do a telephone consultation with her. She said she felt better on the antibiotics and things had improved. So the GP, you send another MSU and you give 3 days of nitrofuran tone again, and that's confirmed as being an E. coli UTI in the sample. They then present again 4 weeks later with the same symptoms, and the patient's getting fairly irate at this point. You know, what's going on? Do you know what you're doing? Do these sorts of things. So we've got this really helpful guidelines here on the press portal, and if you're not aware of them, I just highlighted them here on the press portal, and I can tell from the letters that lots of people are using these, and that's great to see because they are very useful. But there's two things I want to pick up from what I see from the letters that come through. The first of this is, what does it mean if people don't have a positive MSU, and is that relevant? And there's sort of a theme in that people say, well, is it a proven UTI, or was it a really UTI that time if it was a negative MSU? Well, there's a number of studies looking at this, and they compare MSU versus PCR, which is looking for bacterial DNA fragments. And they don't always correlate, and they reckon as much as 1 in 10 MSUs can miss a bacterial infection. There's also other factors as well, like E. coli can replicate better in the culture medium, which means that it might miss other pathogens. So yes, interestingly, MSUs are not the whole story. The message here really is, if they've got UTI symptoms, so dysuria, frequency, urgency, low abdominal pain, and their symptoms resolve with antibiotics, then you can be on pretty safe ground. This is UTI, regardless of what the MSU shows, and you're safe to use the recurrent UTI guidelines. So thank you very much for that. The next thing I want to pick up on is prophylactic antibiotics. Now my learning point here is, I would love it if we could rebrand these as prolonged treatment course antibiotics. So the reason for this is that, you know, there's obviously a reluctance to use prophylactic antibiotics, in as much as, are we just masking the cause, are we not really getting to the root of the problem, doctor? Whereas actually, if we think about it more as prolonged treatment course antibiotics, what's going on here is that E. coli, you've got these sticky bits on the outside, it sticks to the bladder lining, and then it can bury into the bladder itself. And what can end up happening is that you clear the initial infection with 3 days of antibiotics, and then these bacteria that have got stuck in the bladder wall, as it's shedding, they get released and reanimate and start an infection again. And that's what's really going on for these recurrent UTIs. So the idea being that you treat the initial infection, and then with the 6 months of antibiotics use after that, you actually clear the infection by catching the stragglers after that. And this really works, you know, anecdotally. You know, we don't see that many patients that end up being referred again saying, you know, we just masked it for 6 months. Actually, this works for other patients. So yeah, prolonged treatment course antibiotics. With that explanation, hopefully patients won't end up needing to be referred. The other thing, of course, is on this guideline, as well as using the prolonged treatment course antibiotics, you'd be getting an ultrasound renal tract, and that would help pick up if there's another reason why they're getting recurrent infections. So yeah, I've just put this scenario back up again because I think this sort of exemplifies what's going on, that it is this reanimation of the bacteria that's been buried in the bladder wall that's causing the problem. So yeah, which leads me on to my next scenario here, so they do link. So imaging queries. So this is a heart thing for us, and it sort of stems from the reports that we might get. You know, say this lady, you sent her for an ultrasound scan, and then you get this report back saying, there's an unexpected finding and urology opinion advised. And I think, again, if I could rebrand this, what they really mean is, please have a look at your local urology guidelines. The reason for that is because, you know, it'd be great if we could make sure that the reports and radiologists were very clear and had run it through these guidelines for us, but with lots of external reporting done for STH, it means that we can't make that happen, although Rowan is doing a bit of work looking at it at the moment. So the one that I wanted to really highlight to you is this renal masses guideline. And I've highlighted it here on the press portal for you, but some of you may well be aware of it already. But the reason I think it's really good is because very clear, it's got lovely flow diagram, essentially all routes lead to a CT contrast initially, unless it's a simple cyst. And they want to pick up on one area on this in particular, which is the angiomyolipomas, because these are a really common one that comes through, and I think it's a really easy hit. But the guidelines are all there, and all I tend to do is look at what you guys have put and say, well, actually, it fits here, and they don't need any more action or whatever it might be. We're recognising that imaging queries does form quite a lot of the referrals, and we're working on some other ones. And the one that we've got in the pipeline at the moment is the microlithiasis one. So not to confuse things, it's not a renal mass, that's a testicular ultrasound finding. But we are working on putting something together for that one, because again, it doesn't always need to be referred. Okay, so I'm doing it all right for time, I think. So yeah, so this one's a really interesting topic. So assessment of male lower urinary tract symptoms. So I'm going to talk you through a scenario. So Brian is a 70-year-old man who presents with nocturia. You inquire about other lower urinary tract symptoms, and you say any of those. So you do a DRE, and it's normal. You check his PSA, which is 2, so that's nice and normal. You then follow these really good guidelines on NICE CKS. I'm sure you're all familiar with these. You can see they're in purple because I look at them regularly. And from there, you decide you're going to give him some tamsulosin. So great, that's giving him that for a month, but he comes back and says, look, I'm no better, doctor. So then you follow that guideline again, and it says add in some solifenacin, so you try that, and again he says, I'm no better, so you decide to refer him to urology. And this is where we've now caused a bit of a problem, because I think we've dropped the ball a little bit, and I put this in as we as the health profession, because he doesn't actually have a urological problem. And I picked nocturia because nocturia is a bit of an ugly duckling symptom of the lower urinary tract symptoms, because it is a multi-system problem. And I think we are really well placed as GPs who are generalists at recognising that this probably needs a generalist approach to look at what the trigger might be. Now, I've done a little bit here about what causes nocturia and what makes you go to the toilet. And I think the principle for me is we can all relate to that thing of being woke up in the night for something else, and then thinking I might go for a wee and that might help me get back to sleep. I'm sure that happens to lots of people. And that's essentially what's happening for a lot of patients here. The signals that go to the brain during the night that are saying the bladder is full are there and present, but normally you're in a deep enough sleep that they're suppressed and you can manage until the morning. Interestingly, they would say that nocturia even once at night is classed as abnormal, but most people could probably correct that with some fluid restriction or caffeine, etc. But I suppose the point is thinking about what things make that person sleep light that means they might wake up and think they need to go to the toilet for a wee. And so, yeah, it requires a generalist approach and thinking about all these different systems that can cause it. So common things that how do we avoid it, things that we might think about. So heart failure, is this orthopnea, is this PND? We're a nation that's getting bigger and fatter. Is it obstructive sleep apnea? Anything that's making them wake up, is it pain, is it depression, they've got early morning wakening. So again, as GPs, we're very good at this, and so yeah, casting the net wide. This is a slide from this paper looking at assessments of nocturia. And actually, I think their questions are not as good as ones that we might come up with to sort of do a systems inquiry as to what might cause it. But yes, a generalist approach is definitely what's needed. And the worst case scenario here is that we, unfortunately siloing this into being a urological problem, we are potentially causing harm because, they might be having tests that they don't need, they might have drugs they might need. If they're really unlucky, they might have an operation they don't need. I'm sure that doesn't happen, but that's always a risk. So yes, generalist approach definitely needed. The next thing about this, so yeah, how do we ensure it? So giveaways might be the IPSS score, so I'm sure you'll be aware of this. This is the International Prostate Symptoms Score. And actually, what's missing off number 7 there is nocturia. So you can see it kind of sits separate to the other lower urinary tract symptoms. And I guess there'd be a mismatch here, just nocturia and nothing else. That's ringing some alarm bells. Cast the net wide, ask them more about their sleep. think about doing an Epworth score, consider doing still doing your DRE and PSA if needed, but what about BMP at the same time? What does your gut feeling tell you? Do you really think this patient's got a separate urological problem going on? Yeah, I think I'd wait for those sorts of thoughts. The second way we can add value for these patients is if we change the scenario slightly, I'm going to give you a bit more information. So this chap's actually got a past medical history of hypertension, heart failure, atrial fibrillation, type 2 diabetes. He's got drug histories on sacubitril valsartan, which is interesting, like the name. He's on empagliflozin, frusemide, spironolactone. It's a surprise to nobody that this chap's got nocturia. He's on 4 agents that can cause nocturia or increase urine output. I think we've got a role to play here in managing the patient's expectations, where we say actually a degree of nocturia is to be expected for you. You're on drugs which are strongly evidence-based that are going to reduce your morbidity and mortality, and putting up with a degree of nocturia is probably in your best interests. Or, again, what we're good at, should we be saying to him, you know what, this is really ruining your life? Are we at the point where we want to think about de-prescribing some of these things? You're on them for their prognostic benefit. Would it be better to think about coming off these things? So yeah, and I think, I'm not saying we would jump straight to this conclusion, but I think you would have a conversation where you would say, we would check your urinary tract with the usual basic tests, but you can say to my gut feeling is this is most likely a side effect from your medication, and actually, we may not be able to improve that a great deal for you without causing other harms by polypharmacy, etc. I think one of the problems with this sort of assessment, though, is, and I have a lot of sympathy, is that this is not a 10-minute consultation, it's not even a 15-minute consultation, and it's normally thrown up as while I'm here, this problem's causing me lots of bother, please could you sort out my nocturia? And of course, like a lot of things, simple problem doesn't necessarily have a simple solution. So yes, so that's my bit on assessment of urinary tract symptoms. So yes, onto the final home straight now, so I hope I'm doing all right for time. So this is an update about PSA and prostate cancer screening. So, interesting stuff here. So the first thing is that you'll be pleased to know is that the stuff we learnt at medical school about the benefits and harms from the whole population screening program are still exactly the same, which is that we think that doing a population-wide screening system would cause more harm than good by doing overdiagnosis, overtreatment, compared to the lives and harms that would compared to the lives that would be saved by implementing a screening program. What's not changed, but what is new, sorry, is that we know that patients who have increased risk factors, so we know that Black Afro-Caribbean ethnicity, having a family history of prostate, breast, ovarian cancer increases your risk, and if you're a BRCA1, BRCA2 gene carrier, those things increase your risk. So what happened end of last year, the National Screening Committee published its draft guidelines where it was widely assumed that they were going to say that there should be targeted screening for these at-risk groups. And the targeted screening that was on the cards and is still being debated is whether that includes a PSA plus or minus a prostagram. So prostagram is a new term that is basically the rebranding of multiparametric MRI. And they're intentionally trying to make this a word that mimics the language of mammogram. It's sort of got connotations of it's your duty to go and get this checked, so they're leaning into that kind of side of things. And they're also trying to make it something that patients can talk about. This has to be something that creeps into their conversation so they can say to their friends and colleagues, oh, I've been for your prostagram. So that's intentional, what they're using there. So what actually happened, so we thought that the targeted screening was going to be for all these at-risk groups, but actually they just said it's for the BRCA1, BRCA2 gene carriers. And they also said only between the ages of 45 and 61, and there was sort of people thinking that that should be longer. And there was also saying it should only be every 2 years. So yeah, so that's when Wes Streeting stepped in and said that he's going to go away and look at the evidence himself, because there are obviously pressures that are going to say why we're not going after these other at-risk groups. I think there's something for us to think about here, and we are getting slight, callbacks to the situation we had with the shingles vaccine, which was that turns out our coding and identifying these patients wasn't very easy. And you'd like to think if we're going to go for these groups, ethnicity should be self-declared. Family history of prostate, breast, ovarian cancer, we don't record that as a read code in the notes, so maybe that's something we might think about. And I'd like to think that if you get a patient who is positive for BRCA1, BRCA2 gene carrier, that should be coded in the notes, but add it to our list of things to worry about later, I think. But yeah, so this is on the card, it's what they're thinking about, and there are trials going on at the moment to see whether the enhanced screening includes just PSA or includes the prostagram as mentioned earlier. So that's the important update about screening programs. Worthwhile saying there's been a bit of an update into what we do. So the current system we have is that we know on a population level that we don't want to be testing everybody, but we would encourage people who want to know their risk to come forward. So we have this opt-in system where people who have made the decision that they are happy to consider overdiagnosis and overtreatment, they can opt in and say, I would like to have my PSA checked if they're over 50. And we have this system where we look at the symptomatic versus the asymptomatic thresholds. And if they're referred on a 2-week wait, there has been changes in that in the not too distant past. So now first-line investigations are multiparametric MRI or prostagram. And again, this has been revolutionary, it's non-invasive, it's well tolerated, not really any risks. And then the next step from that, if they do need biopsies, they're now done by transperineal, by transrectal, and that's had a big impact on the complication rate. So there's a bit of a change there. It's worth saying there's no modifiable risk factors for prostate cancer. It's not related to smoking or lifestyle or anything. It does seem to be that your risk is your risk, and that's that. But the thing that I wanted to take away from this section is this new change that came in the summer last year. So Prostate Cancer UK did what they call consumer level research, where they said to a group of men, saying, what is it that stops you coming forward and having your prostate cancer risk looked at in more detail? And a lot of them said that the DRE was a big barrier to them coming forward. And worst of all, it seemed to be that was more prevalent in Black Afro-Caribbean cultures due to stigmatization. So we were potentially part of the problem there. So then they did a bit of a deep dive into what the evidence is for doing a DRE. And it turns out actually it's not that useful, that it doesn't add that much to what we know their risk in terms of evaluating it. And actually, if we're causing harm by meaning that patient means they can't go back and tell their friends they've had a prostate check and all that sort of stuff, but actually it's gone. So the message is, if you are still doing DREs for asymptomatic patients who are asking for prostate checks, that's outdated now, we shouldn't be doing that, and we should just be doing a PSA. And my caveat to that is that, of course, sometimes patients come forward and say, I'd like to have my prostate looked at in more detail, I'd like to have a PSA, and they think they're in the asymptomatic group, but actually when you dig, you may well find they've got a degree of nocturia or other lower urinary tract symptoms, which then moves into the symptomatic group. And symptomatic patients with even a normal PSA, if they've got an abnormal DRE, that would be an indication for a 2-week wait. So I don't want to confuse things too much. The message really is, in the asymptomatic patients, you don't have to do a DRE, but in the symptomatic patients, it would still be advised. That said, there is a little bit of wiggle room where they've said, if they decline, don't let that stop you doing a 2-week wait, which is fairly obvious. You're not going to sit on a raised PSA and say, I'm not referring until you've had a DRE. So yes, that's that. And hopefully I've covered everything in enough time. So I'm going to leave up there my summary of my main learning points. Sorry it's been a bit of a whistle-stop tour through those topics, but hopefully there's some nuggets in there that you'll find useful. We have only got 35 minutes for the urology section, so we're going to hold questions until after Magdi's section. But if we don't have time for questions, more than happy to field those via email. So thank you very much.
Hello, good afternoon everybody. I'm Magdi. I'm one of the GPs in Sheffield, and I'm one of the urology peer reviewer with Craig and Rowan, which is unfortunately couldn't make it today. We are pleased to have Mrs. Beverly Wilkinson, the consultant urologist at STH, and she's also our mentor. Before I start, 2 quick points. One, I used ChatGPT to choose this kind of interesting title, but I promise you the rest of my slides are not AI generated, it's my own work. But I can also promise you, in few years' time, it will be Alexa or Gemini or Siri who will review your referral letters, not me. The second point before I start. I was thinking about the theme of the meeting today about dizziness, and I was thinking about the urological causes of dizziness, and I think somebody on tamsulosin or alpha blocker who has got postural hypotension, they might feel dizzy. If somebody having a massive visible hematuria, they might feel dizzy. But I'm afraid we are a surgical specialty, so it doesn't apply to us. Oops. Natalie, help. So, guidelines, we all love guidelines, whether national or local guidelines, and we work closely with STH team to produce our local guideline. So this is not a comprehensive list of what we use, but you probably have seen it before from our replies. We use the press portal, we use the Great GERFIT nowadays, which is the National Advice and Guidance templates. GERFIT stand for Get It Right First Time, and we also have our page on primary care Sheffield. So we review the themes of the referral we receive every time, and we always try our best to produce our local guidance or pathways to help everybody like myself when we work in primary care. And as you can see, we recently added the hematospermia. There's also guidance for scrotal lumps, which does cover hydrocele, varicocele, epididymal cysts, and Craig already covers the recurrent UTI. And we are working now with the Sheffield Teaching Hospital team to cover one of the difficult topics in primary care when it comes to urology, which is a chronic testicular or scrotal pain and chronic pelvic pain, and I put in brackets chronic prostatitis. So my talk today, I'm gonna speak about hematospermia, and I'm gonna talk about the chronic testicular and the pelvic pain. Already Craig covered the recurrent UTIs, the PSA, and the other thing. Chronic testicular pain, I personally consider it one of the heart sink patients. I'm sure you are all agree with that, and possibly the team in secondary care will agree with that. It's not uncommon. 10% of the referral the STH receive from primary care is chronic testicular pain. The very first question we need to ask ourselves, is it actually testicular? Could it be anything else? Could it be a hernia? Could it be a radiating pain with any other pathology which is radiating to the scrotum, giving the patient a chronic pain? So as we always do in primary care, we take a good history and then we examine, and we can organize the tests available for us in primary care. So by the time we write the referral letter, the consultant or secondary care has got the relevant information they need, so it will make it quicker for them to put a plan of management and to help the patient. When you take a history, you need to ask them, say for example, vasectomy is one of the common contraception methods nowadays, and we know unfortunately there's a good number of patients who have had vasectomy in the past. They can actually present with chronic testicular pain. You do need to take almost a full history, sexual history, in terms of partner, how many partner, whether same sex or different sex or whatever. You also need to cover the mental health problems with the patient, and we are in a position to have the holistic approach to cover all these points. And of course, when you write a referral letter to secondary care, you need to mention what kind of painkiller have you already tried with the patient, so they don't have to repeat if it comes to painkiller. When you examine the patient, you need to examine the abdomen properly. As I said, you need to rule out any intra-abdominal pathology which might be a cause for the radiating pain, giving chronic testicular or scrotal pain. You need to examine the inguinal area, and of course you need to examine the scrotum, both testes, and if you can, it would be ideal if you refer your patient to get an ultrasound scan for the scrotum, so we can have a good look whether there's any scrotal lumps or anything to explain the chronic pain for the patient. And of course you get the MSU to rule out any infection or whatever. If the ultrasound is normal, most likely, if you think about it, what the urology team as STH will do for such patient, if they have pain, normal ultrasound, normal MSU, you might try different analgesia. And there are evidence-based papers nowadays about using amitriptyline or gabapentin or pregabalin to see worst case scenario. If the patient doesn't get better, which does happen sometimes, then you will refer, and you need to discuss with the patient what could be the possible outcome of the referral. So sometimes they might, in worst case scenarios, to use what we call nerve block. And I've reviewed myself a letter probably a month ago. One of the patients was actually asking his GP to refer him to urology to get orchidectomy. That's how desperate they are, but it is one of the surgical options to deal with chronic testicular pain. Most of the time they need reassurance. If we can't do the reassurance in primary care, we hope that secondary care can give this kind of reassurance. The second one is chronic pelvic pain, and I put here in prostatitis. There's different ways of describe chronic pelvic pain, but most of them in men obviously will be the chronic prostatitis. Again, one of the difficult cases to manage in primary care, and I think again Bev will agree, even to manage in secondary care. 10% of the routine referral are with chronic prostatitis. Same thing again, but the tricky bit with chronic pelvic pain or perineal pain, if you like, that they can present in different ways. They might have urinary symptoms, namely Lot's law or urinary tract symptoms. They might present with erectile dysfunction or ejaculatory dysfunction. So whenever you see a patient with these kind of problem, again, same as we always do in primary care, you do need to ask specifically about all the lot symptoms. You do need to ask about sexual history, any history of STIs or any exposure to STIs. And you ask about back problem, you ask about the mental health, because mental health issue can present in different way. You examine the scrotum, you examine the prostate, and you organize a test which we can do in primary care, namely the PSA and MSU, and I mentioned about STI screening as well. When it comes to treatment, of course, we always think about antibiotic. We know that we recommend a long course of antibiotic 4 to 6 weeks, whether doxycycline or trimethoprim or the quinolones, but we are all aware of the possible side effects of the quinolones. But the point here, please do not assume that keep pouring antibiotic in someone with chronic prostatitis might help. And actually, it is not recommended unless the MSU culture is positive. So please try the course of antibiotic. If no better, repeat the MSU, and if it is negative, they do not recommend any more antibiotic. You can try the non-steroidal anti-inflammatory drugs. You can try the alpha blocker like we use with lots, tamsulosin, alpha-sosin, whatever it is. And of course, if they do have STI infection, you treat it. If they have erectile dysfunction, you give them the PDE5 inhibitor. And again, another recent paper talking about role of gabapentin or pregabalin in chronic pelvic or perineal pain. Like we always do, our main job is to make sure that we don't miss any red flags. If you suspect anything like prostate cancer or whatever, you get a raised PSA, you've got a significant, and I mean significant, lots. And if the treatment, the conservative treatment, is not successful, then you would consider to refer to secondary care with all the relevant information. The last one I'm going to cover is the hematospermia, and you can see the guidelines. It's already on the press portal. Please note it's still on the Sheffield CCG portal. I was talking to Andrea about it, but it's still as it is now. What does it mean, hematospermia? Blood with the ejaculate. There is always a caveat, if you like. Is it just once or twice? The secondary care team, and Viv can correct me if I'm wrong, they like it to be recurrent or persistent, because if it happened just once or twice, forgive me, they won't get excited about it and your litter will bounce back. There are some consultants in the country, I'm not going to say in Sheffield, they say at least recurrent for 4 weeks. Some like it to be for 6 months. So don't feel bad if your referral bounced back because it only happened within 3-4 weeks or whatever. That's the national guidelines. By all means, what we are worried about in primary care, am I missing prostate cancer here? That's when it comes to the red flags. If you check the PSA and it's red outside the age-adjusted range, or if you suspect malignancy on examination with a digital rectal examination, or if the patient has a strong family history of prostate cancer or testicular cancer, these are the red flags. They do need to be referred via the 2 weeks referral. What are the possible causes for hematospermia? Of course, we know UTI can give you some blood sometime in your ejaculate. If you have a recent procedure, for example, vasectomy or prostate biopsy or catheterization or whatever procedure, you might end up with a bit of hematospermia. Don't forget, if you have other bleeding tendency, hematological problem, say hematuria, visible hematuria, or bruising or whatever, you do need, obviously, when you take the history, to cover all these things, including, as I mentioned, the family history. What can we do in primary care before we consider the referral? Of course, we need to check the PSA, we need to check the full clotting screening, we need the LFTs and ideally the ultrasound testes. If you find out it's UTI, you treat it. If you find out it's prostatitis, you treat it, as I mentioned in my previous slide. But if all the investigations are normal, you can just simply reassure. But if it is recurrent, and as I mentioned, 4 weeks, bracket 6 months, that's when you consider the referral to secondary care with all the relevant information. Here is the pathway. You can see here that you get the history, the blood pressure. By the way, I forgot to mention, what we used to call malignant hypertension, extremely rocket high blood pressure, can cause hematospermia or even hematuria, visible hematuria. You do the urine analysis, you do the blood tests, and if the patient requires urgent treatment, brackets any red flags, you refer by the 2 weeks. If no red flags, did you find the cause of the hematospermia? If yes, you treat it, as you can see. If not, then you can reassure. If no better, that's when you refer. Lastly, and I'm going to be very quick because I'm running out of time, if you see somebody with non-visible hematuria, please repeat, because I see letters sometimes with, oh, this guy had a work-related checkup and they found some blood in his wee. Please repeat it at least 3 times, and some recommend to be at least 3 weeks apart. So you do not do the 3 dips in 3 consecutive days. You leave it for a few days and you repeat it again. Personally, and I know the secondary care team might argue with that, I would love to see the microscopy, the official microscopy report from the hospital, whether there are RBCs or no RBCs. Because how often I see a urine microscopy clear, but still the dipstick is positive. Don't ignore it, but you can confirm it with the urine microscopy. And of course, in females, you need to rule out any transient causes like UTI, which is not uncommon to present with symptoms, including the non-visible hematuria. Of course, you ask about the menstrual health history, and you ask about any vaginal bleeding. Ideally, you need the intimate examination to have gynecological examination before you refer somebody. And the last point I would mention, always check young females with positive dipstick, check their blood pressure, check their urine PCR, protein creatinine ratio, because it could be a kidney problem rather than a urology problem, which means the referral should be directed to nephrology rather than to urology. My last slide, I promise. We are, as I mentioned, a surgical specialty. So always discuss with your patient, if they're gonna offer you a surgical solution, would you accept it or not? Of course, we all respect the patient choice, but trust me, the last thing is to end up after waiting probably a few weeks to get an appointment with Bev or one of the secondary care, and they say, oh, you need this or you need do that. Oh, I'm not happy with that, let me think about it. Fair enough, but it would be a good idea if you discuss the surgical options with your patient before you send the referral. And talking about possible surgical intervention, if you have somebody who's diabetic, I'm sure all of us knows that you need to have a good control of the diabetes before they can touch him, and they always are up point about HP less than 70 before they do anything about it. And thank you, and hopefully if we have time at the end, Bev, I hope will be around so we can answer any question. Thank you again.